You're listening to the Assembly on Behavioral Science and Health Services Research podcast, brought to you by the American Thoracic Society.
Welcome, everyone, to another episode of Pulmonary Palliative Medicine with the American Thoracic Society. I'm Patricia Fogelman with my co-host Jennifer Wescoe from the Wescoe Foundation for Pulmonary Fibrosis. And we are just beyond excited today to have as our very special guest, Dr. Yatin Mehta, who is an interstitial lung disease and critical care physician at Geisinger Health System. And I'm going to let him take a few minutes just to introduce himself, and we're going to dive into some fascinating conversation. Dr. Mehta, welcome.
Thank you, Patty and Jen. It's so exciting to be part of the podcast that's heard, very widely across the world. I am Yatin Mehta, as Patty said, and I'm a practicing pulmonary critical care physician, director of ILD program at Geisinger for past 10 plus years. And topic that we are going to discuss today is quite exciting. And so looking forward to start our discussion.
I want to share with our listeners that Dr. Mehta has a very unique connection to palliative medicine in that he is married to Mrs. Dr. Mehta, who is a palliative medicine physician as well. Mm-hmm. And so since he has an inside track to palliative care and its intersection with lung disease and critical care medicine, I thought maybe we would dive in with the tough question first. And so, Dr. Mehta, tell me a little bit about your perspective about the collaboration with palliative medicine, especially as it intersects with interstitial lung disease, and kind of the taboo that often surrounds palliative medicine, and how do you broach the conversation with patients, families, and caregivers, and how do you help, not just the patients and families overcome it, but also even your colleagues and staff providers? That's a great
question, Patty. And when it comes to interstitial lung disease or chronic progressive, fibrotic disease, and IPF being probably the most recognized out of all of them when it comes to chronic interstitial lung disease, there is a plethora of data. These patients actually have significant symptoms that are coming from not just ILD, but because of the situation they are in, which includes, depression, anxiety, insomnia, fatigue, apart from the symptoms that directly originate from the disease itself, which is the, breathlessness or dyspnea. And, managing these is certainly difficult, and finding the right partners, to manage patient symptoms is critical. But having said that, there is a taboo around palliative medicine because oftentimes not just patients, but even providers equivocate that with hospice or end-of-life care. Mm-hmm. And that is certainly, one of the big impediment as to why these patients get pretty late referral. If you look at the published data, for the IPF patients, 70+% of patients will have palliative medicine referral in last 30 days of their lives. And more than 60 to 70% of patients will actually die in the hospital as opposed to probably at home or near their loved ones, essentially. And once you acquire a chronic disease, you certainly have time period to address some of those deficiencies that we see in our healthcare systems across the world for a variety of reasons. And there are a few factors, that actually lead to, apart from the misconceptions about what palliative care is, delayed referral. And that includes uncertainty about the disease prognosis, maybe the providers, their own skills to initiate the discussion about palliative medicine, and then fear of prescribing medications that may help assist patients' symptoms, so on and so forth. So there is, one aspect is essentially the taboo around palliative medicine, which we know for any advanced lung disease should really be part and parcel of their care plan and not just as an end-of-life, management tool. Then the second piece, as I discussed, is the provider's, own limitation that comes, from disease prognosis and the skills to, initiate the discussion.
Dr. Mehta, being a patient advocacy organization and working very closely with patients, care partners, really in the trenches and navigating pulmonary fibrosis, ILD, and having the opportunity with supportive care through this whole wraparound approach and having these conversations. And really what is so important is also in the big pictures, not only with providers, but with patients and care partners, and educating them in having this information to then be that catalyst in the conversation and talking about palliative medicine. And Dr. Mehta, you had mentioned it about a taboo type of topic in terms of prematurely getting to the place of advanced care planning, when that's so essential in making sure that the next steps in navigating pulmonary fibrosis, ILD, are looked at in a way that one is prepared. And being, like I had mentioned before, being a patient advocacy organization, working with patients and educating and having that opportunity to do that collaborative partnership with providers in palliative medicine and providers in that space really coming together and having the resources for the community to then bring it into the appointment with the pulmonologist or whomever that you're talking with. Hey, this is something that I would like to learn more about. We do a lot of that in our support groups and education programming as well. But what other ways can we really bring that to the forefront to making sure our community, patient-led, care partner-led, to make sure that they are bringing that into this conversation? Education is so important, of course. But what other ways would you recommend for the patient and care partner community to really be a catalyst in that process?
It really starts with the education of patients themselves and about the role that palliative medicine can play in chronic diseases. Oftentimes, just like as I was mentioning earlier, where the providers, themselves equivocate palliative medicine with the end of life and hospice care, patients have the same perception at times. And when we are talking about, on one hand, therapies that can actually improve their longevity and with the intent of even if not cure but management, we need to introduce the concept of palliative medicine to the patients themselves, saying that this is not really because death is imminent, or this is just because you have a disease that's going to be lethal in certain time period and so on and so forth, but rather saying that these are the partners in your care team that are going to assist you as we go through the journey in this disease that we know is not curable as of now, but only manageable. And educating about the role of palliative medicine to the patients themselves, I think, is critical, as it is, for the providers who are providing the care for them. And as you know, in medicine, the care is never delivered, by one person or one team. It takes the village to provide the care. And palliative medicine is part of that village when it comes to chronic disease, especially interstitial lung disease as such.
And I think this is so important because I think these conversations about prognosis, especially with ILD patients, has a substantial amount of variability, right? Because it's dependent upon their performance status and their age and time of diagnosis, and at what point in this trajectory are you seeing them? And, what are the interventions that you can offer at those points? And so I would want to ask you, following along with what Jen is saying, how do you initiate these prognosis discussions with them? Kind of that very nuanced balance, right, of hope with realism, and then kind of how does that segue into like that collaboration with palliative medicine for these folks? And so I think it would help us to maybe hear a little bit more from you about the prognostic variability of ILD from your perspective and experience, and then kind of how do you initiate these conversations with patients?
Absolutely. I think that's a great question. And I would like to, provide some practical pointers, that providers can use, because we talked a lot, in the beginning about timing of referral and prognostication. And so, what do I use, what is my threshold to refer to patients with palliative medicine? Certainly, you can use disease severity scores, such as GAP score, which is one of the scores we use for patients with IPF, and somebody with the moderate and advanced disease. You can use that as your trigger if you are a person that relies on objective data. But some other practical pointers for referral would be, if a patient with interstitial lung disease or IPF requires hospitalization, that really should trigger, a referral to palliative medicine, because oftentimes that tells you disease severity and potentially about the trajectory. Any patient that is oxygen dependent, that I use as a threshold to introduce the concept of palliative medicine for symptom management. So those are some practical pointers that our listeners can take from this. That those are the three at least ways I actually assess when is the right time to refer the patient. And earlier the better. We know that there is a data in cancer literature that earlier involvement of palliative medicine improves quality of life and in these patients and improves outcomes. And ILD is not different. We just don't think of ILD in the terms of cancer. And for even though we know that the median survival for some of especially for IPF is 3 to 4 years. So we really need to think along in those terms. And those are some practical pointers for the providers when to actually initiate conversation. And then comes the how to initiate the conversation. That's the second piece you asked, Patty. And how to do that is, again, I'll go back to framing the palliative medicine in the context of a care partner rather than end of life situation referral is, I think, critical. And so that they feel that this is not because I'm going to die or I have a poor prognosis and hence I'm being referred to palliative medicine. I think the perception around the palliative care really needs to change. And so I think that starts with the provider themselves having the clarity when to refer, and then discussing that with the patient and putting it in that perspective that this is not because you're going to die, but this is because we want to provide you the best quality of life, which we know that is not always feasible in the lung doctor's office. We are very good at addressing interstitial lung disease, their treatment options, managing probably their symptoms such as dyspnea and maybe cough. But when it comes to their emotional needs, their spiritual needs, their social needs, we may not often do a great job. And that's the deficiency that I see that palliative medicine will fail. And that's really the education we want to provide to the patient, that there is not just the symptom and the disease aspect that we need to manage, but we need to manage the person. And that whole person management can not be done by just pulmonologists. So, I think I'm going to earn a lot of bounty points with my wife today, but
you are. I say that a lot. I mean, Jen's heard me say that. I say this in teaching and academics to patients, the residents. The whole person is this entity that extends beyond just the patient, right? There's a family, there are children, there are caregivers. So whole person care has to take into consideration kind of the whole of the entity that you're serving, right? And at the end of the day, we're in service to our patients and to their families. And I think that balancing hope with realism is tricky, right? Because there's a comfort level that's required. There's a certain level of gravitas that we need to bring to the conversations. But then there's also kind of, if we're honest as providers, and we've all been there, a certain amount of courage that we need to have and then build and sustain to keep having these conversations. So if I was your new ILD patient in your clinic with you, and I come in and I just started oxygen therapy and my pulmonologist sent me to you, but I don't know my lung function at this time, but it's not great, and maybe my GAP score is moderate. How would you kind of have that initial conversation with me? Like, if I said to you, like, I don't know, doc, I'm here for you to fix me, which is, I hear this a lot, right?
This is a bit of role play here, isn't it?
Yeah.
But
I feel like putting people on the spot to really add to the value of the experience.
I think it's, it's the way to frame that conversation, how I go about, doing that. What I would say to you, in that situation is that the disease education, that we are dealing with a serious disease. We know that it has a progressive nature, and we are going to do everything we can to prevent that disease from progressing while giving you the best quality of life, in which we are going to use therapeutic options. We're going to use the options of, exercise. We're going to options of, symptom management. And part of that symptom management that improves your quality of life and keeps you functional is involvement of a specialty that actually can assist me in providing the best care for you. And I think that is real, and would you be open to that, idea, care plan? And I think that often gives them the opening to ask further questions about palliative medicine. So that's really how my pitch to that patient is.
And I think that's amazing, right? Because there's literature that says when we explain something to our patients and then follow it up with, does that sound reasonable to you? the extension of the question is really, I'm collaborating and in partnership with you. And does that sound reasonable? Also kind of says, I think it's reasonable. Do you think it's reasonable? And, if we can agree on that, we can follow down a path. I would then kind of say, though, I think when you have these conversations, you're dealing clearly with very sick patients, with very advanced lung disease. How do you manage kind of the emotional weight of these conversations? Because you're a critical care physician, you're an advanced lung disease physician. So in all honesty, the emotional weight of the conversations you carry on a regular basis is fairly high. And so if you're speaking on the level of physician to physician or providers to providers, how would you kind of address the emotional weight of the conversation, and how do you balance that?
Yeah, that's always tough, isn't it? It's not easy to have these conversations over and over again, right? I mean, so there is a certain amount of, skill that's needed to deal with those conversations. Those conversations are easy, certainly for the providers, as much as they're not easy for the patients at times. And putting yourself in the patient's, shoes, I think, and that empathy, that one needs to, have in patients who are in, with the serious disease, I think really helps balance that conversation with the patient. And that's what I find that is helpful in bringing that patient the ideal, care that they need.
And have you found, Dr. Mehta, have there been like these high tech type of interventions that you think are either overutilized or underutilized or have low utility? So are things like high flow nasal cannula particularly effective in the long term for these folks, or particularly helpful? Like what would you say of these existing therapies right now that you find helpful versus not helpful?
That's a good question. I think what we should probably talk about what's the most helpful that's proven by literature, right, for these patients. And I think one of the most important, there are two things that rise to the very top of what's helpful. One is a pulmonary rehabilitation, which we know has proven benefits in improving quality of life, functional capacity. And data says that, once the patient goes through the pulmonary rehab programs, what they get is essentially improvement in their FVC as well, not just their improved quality of life from building the exercise endurance. So that's, definitely, one therapy that's very helpful, and oftentimes not often available to the, the patients in all the locations in Georgia, depending on where they live and proximity to a center that provides that service. The second is assuring appropriate oxygen, dosing. And that, I divide that into two different categories. Is this a patient that, really has a good functional capacity and still has mild disease, and what will keep them mobile? Because we know that carrying oxygen tanks are not easy at times for these patients. There is a certain amount of difficulty that comes along with that, and change in lifestyle that it requires. And so there are patients with, let's say, mild to moderate disease that can easily, use that oxygen therapy to improve their quality of life, exercise endurance with the portable devices. So that I find very helpful for those patients. But then there are some patients who have truly advanced disease where portable concentrators themselves do not provide sufficient oxygen dosing. And in which case, the best source would be the liquid oxygen, which is often difficult to deliver at their home. But continuous flow liquid oxygen, really works probably the best. I'm not so sure, that high flow nasal cannula oxygens have that much, utility when it comes to, longer term, because they are not easy to tolerate. The flow being higher is not always comfortable. And there are other ways to improve their dyspnea if the advanced disease gets to that point. We haven't talked about some of the pharmacotherapy that we could use in those patients. So oxygen by itself may not be the only therapy that we would employ for those patients who have very advanced disease. And I'm sure we'll talk, more about symptom management when it comes to dyspnea, apart from the pulmonary rehab and oxygen therapy that we just talked about.
Well, and since you opened the door, let's talk about the symptom management, because you've noted, and I think this is important, that these patients struggle with anxiety, insomnia, dyspnea, fatigue, and probably all of those are top symptoms, right? As far as intensity, I don't know that any one is less intense than the other, because they can feed into each other. And you and I have shared patients, right? And so dyspnea and anxiety just becomes this vicious circle. So if you're seeing them kind of at those initial visits, like what are some of the medicines you like to consider using to kind of intercept that cycle of intensity for them?
Yeah, that's a great question. I divide them into two categories. The categories that I'm very comfortable prescribing, and the categories where I need my partners to prescribe, right?
I love that answer.
So that's in my mind. That's how I divide the treatment for when it comes to symptom management. So let's just start with the dyspnea. And so in my wheelhouse to alleviate dyspnea is finding them a rehab program, finding them appropriate oxygen supplementation. And if that is not sufficient and dyspnea remains a persistent problem, especially with advanced disease, then that's when I call my palliative medicine colleague and say, I need help in helping this patient. And because they are so much better at managing that symptom with opioid therapy, which for most pulmonary physicians, I would say that they are not always comfortable prescribing and managing chronic opioids, drug change, changes in the opioid formulations themselves, how to dose convert, so on and so. There are so many nuances to prescribing opioids that I've learned through my collaboration with the palliative medicine, that I certainly feel that's the the service that provides the best when it comes to symptom management. So that's when it comes to dyspnea, which is one of the biggest symptoms. The second is chronic cough, and that's always a challenging symptom. We can certainly provide the therapeutic options from the and non-therapeutic or what I call other supportive treatments when it comes to hot tea, honey, some lozenges, Tessalon pearls. Some patients would respond to those. There are some that just have intractable cough, and I've used Neurontin or gabapentin for that purpose, for management of cough. And those are the medications, again, I say within our wheelhouse. But opioids certainly help with the symptom of chronic cough as well. So if you have a patient that has progressive disease that is suffering from significant dyspnea and cough, again, the role of palliative medicine is critical in managing those symptoms along with that.
And would you use nebulizers for these folks? Is there a role for nebulized medicine in this population? Because I see that ordered so often, but
yeah,
the question is there a valid utility to it?
I don't find them particularly helpful, in this patient population, just because oftentimes these are coming from the distortion of the airway rather than inflammation and reactive airways, which is what the disease pathology of IPF or any chronic interstitial lung disease would be. That these are the patients who have abnormal morphology of the airway, which is very difficult to address with inhaled bronchodilators or inhaled steroids.
And so Dr. Mehta, let's unpack that for a minute, right? Because the knee-jerk response when someone comes in and we're short of breath is to order the bronchodilator, right? And then the equal knee-jerk response of comfort is to sustain the bronchodilator, because finally, from a provider perspective, that's what helps breathlessness, is our generic thought, right? It's what we've accepted as a conventional practice. And so then it becomes on some level kind of, it's not a crutch, but it's kind of almost like this anchor, right? Patients buy in, like, oh, if I don't have that, I won't breathe well. That's what they told me. But can you explain a little bit more about kind of the airway issue and kind of why a bronchodilator or those medicines won't be particularly helpful to ILD? It's such a key piece of therapy, right? You don't want to order things that aren't necessary, but you also want to not give false hope that a medicine's going to work if it really isn't.
Right. I think, that's absolutely one of the diagnostic criteria, right, especially for IPF, we use on radiological findings is development of traction bronchiectasis, which ultimately leads to honeycomb changes. And what that changes the morphology of the airway. The fibrosis in the surrounding lung tissues opens up and increases the size of that airway, which is what we call bronchiectasis. But this is unlike any other bronchiectasis that you see that results from infections or occurs in the setting of asthma, which are all primary airway disorders. We are in chronic interstitial lung disease. You're really dealing with primary parenchymal pathology, which ultimately leads to changes in the airway. So that's the difference in the pathophysiology of airways disease, and why the symptom of cough appears. And in that situation, using bronchodilator isn't going to assist that patient's or improve that patient's symptoms just because the etiology of that traction bronchiectasis is actually originating in the pulmonary parenchyma and the fibrosis that's present in the pulmonary parenchyma.
Mm-hmm. That's an important question.
Mm-hmm.
So from the treatment perspective of interstitial lung disease, like what are the options that you've been able to offer patients, and what potentially kind of lies ahead, from the perspective of realistic hopefulness for them?
Right, great question. I think I would divide them into two different categories. One is IPF, and the other is non-IPF chronic progressive, ILDs. So IPF, we know there is strong data that from the disease management, is the two treatment options that are available is pirfenidone and nintedanib. Those two, are proven to reduce the disease progression and oftentimes acute exacerbation of the IPF. And that's the treatment that we would, one of the two options are perfectly reasonable options to use for patients with IPF. When it comes to non-IPF, what we really have data for is if you have non-IPF ILD, so essentially, NSIP that's resulting from chronic tissue disease and fibrotic NSIP, or you have patients with occupational lung disease that leads to fibrosis, or for patients with advanced stage 4, what we call fibrotic sarcoid. So if you have progressive disease, that means there is a change in your FVC on a year-over-year measurement of greater than 5%. Then in those patients, there is a role for antifibrotics as a disease category, preferably nintedanib in those patients. And so those, are some of the pharmacological ILD specific therapies that are available. Now, so that is, focusing just on fibrotic component of most of these interstitial lung disease.
Right. And are there other more aggressive interventions that we can offer these patients? So if the medicine is kind of, that's one level, right? That's the medical management. Are there those other interventions that are kind of beyond that? And if so, who are they most appropriate for? Like, how do you select, the population?
And I think just like patients, when they get diagnosed with this disease, especially IPF, where we know the median survival is 3 to 4 years, we want to make early referral to palliative medicine. We also want to make early referral in appropriate patients to actually lung transplantation.
Oh, tell me more about that.
That's the curative option, that we are looking for. So not all patients will qualify for, unfortunately, interstitial lung disease often gets diagnosed late, just because of its insidious onset. And initially the symptoms are attributed to either aging, I'm just slowing down, so there's often a delay in diagnosis. And once the disease is diagnosed, it sometimes is often too late for some patients where they're not a candidate for transplant. But then there are patients with the family history of IPF or a variety of other, or maybe they're just very active and they notice early onset of disease because they become limited and they say something is wrong. And so we do come across, quite a few number of patients where the disease is diagnosed rather early and they don't have, comorbidities, which makes them a candidate for transplant. So I think while we focus on, a lot of our conversation focused on, patients who are with advanced disease and, where they may not have that option available, but that certainly is an option available for patients in certain age group with their functional capacity being intact, with less medical comorbidities, because that's the only, curative treatment that we know so far. We don't have other curative, treatments that are available for patients with IPF and other types of interstitial lung disease.
Dr. Mehta, when, sometimes with the wonderful patients that we work with and their families, and, we're leaning into a lung transplant and all that's involved with it, and staying the same vein of palliative care, palliative medicine, sometimes these questions come up is, can I still be using the opportunity of palliative care, palliative medicine, while navigating or even decision-making pre-transplant? Is this something to think about in terms of, okay, let's go in this direction? Because, pre-transplant, there's so many questions of, in fact, do I want a lung transplant? What does it involve? Evaluation, surgery, post-transplant. And so this is a very integral part of decision making of moving into palliative care space for the patient and their family. So, right, it's a complete village, exactly what you said. And so in educating through the process of, talking with patients and making sure that they know that this is something that is still an opportunity for a lung transplant. Can you share more about that?
Sure. I think we can put this in perspective. When you have any kind of advanced lung disease or any advanced disease for that matter, the way we want to view palliative medicine is that upfront, when the diagnosis of a condition happens, you really have a bigger chunk of time devoted to the treatments that are directly geared towards improving the disease process or preventing the progression of that disease process. And palliative medicine may play maybe a smaller role, but that equilibrium changes in the favor of palliative medicine. And it should be a smooth transition because we have introduced palliative medicine early on as a care team partner. So that transition becomes a little bit easier as the disease advances, and then palliative medicine will play probably a larger role than your lung doctor would play. So I think that is a continuum in my mind, and with the early involvement, that continuum can really progress smoothly without having two different distinct care plan episodes that, hey, first 50% of your disease process was managed by a lung doctor and next 50% will be managed by a palliative medicine physician. That really is not the right model. The right model is early introduction and bigger role as the patient's disease progresses and the disease specific treatments are not as helpful, but rather symptom management becomes more of a focus for that patient. And transplant conversations are around the same idea. Yes, it is a choice that it's a big deal. Lung transplant is not easy for patients to go through. Certainly provides them good longevity, and in a right patient and in a right setting, it's an absolutely wonderful option. But then there are patients who would say that maybe I do not want to go through all that, even though it may be an option for that, and it's a patient's choice. Having palliative medicine as part of that conversation, is certainly helpful. So if the patient decides after understanding risk, benefit, advantages, disadvantages, that I do not want to go for transplant, you have palliative medicine as part of your team. I must say that for full disclosure, I do not work at a transplant center, but I do share a lot of my patients with the transplant center where I refer the patients for transplant. So we do see those conversations, for those patients.
And that I think that's a great place to also ask the question of, we both have a history of practicing in urban centers and then having come to a rural setting for our continued careers, right? And your setting actually is a level 1 trauma center. So you have plenty of high tech, the nature of support is high tech. And so would you say that there's this perceptual difference in rural health versus urban health when options like transplant are being broached? Is there some, not necessarily discounting of it, but is there a pragmatism that comes in a rural setting that isn't in an urban setting, or is it more difficult to want to pursue because there is that kind of distance, right? So we don't have transplant centers in our backyard in urban settings, right? We're often hours and hours away from those places, and that can be a deterrent, right?
Certainly, I think the distance is the key, here, and the access is the key. It certainly is much easier to be close to a center that provides the lung transplantation than it is not. I mean, there is no doubt about that. Just because the commitment that is needed on the patient side to be a candidate for transplant are significant. And we, as a provider, may not often realize that, but often it requires for them to move within certain distance of a transplant center in case the lung becomes available. The changes they need to make, the financial burden of that, the anxiety that surrounds the entire process, and mind you, a big surgery that's waiting for them. So I think there are so many factors that are involved when it comes to lung transplantation. It's not just a simple referral for a surgery, but it's rather involves a whole lot of that. And Patty, I think access to a quaternary care center that provides a transplant service is certainly a key factor. I can tell you from my personal experience and anecdotes that there are patients who have elected not to undergo transplant just because all of these changes they needed to make given their geographical location of primary residence. They opted not to, go through, apart from other, reasons and their beliefs. But, certainly the distance from the center, did play a role in their decision.
Patty, that's a great question. Rural population and urban, where you are, and the accessibility, the time that's involved, and Dr. Mehta, the anxiety, the logistics, everything involved. That's a huge decision to make, and it's such a pendulum. And I know we're kind of diverting into lung transplants. Such a personal decision, all that's involved. We have some patients are saying absolutely not, to in the interim to saying, well, of course I'll have a lung transplant. And so, and having palliative medicine along the way to help support you and continue that quality of life is another wraparound approach, another level, as we always say with palliative medicine or care, is that other level of support to get you to that point. And so thinking about that as well, I think that's just such a great point to make and a great question. Mm-hmm.
So Dr. Mehta, I have a question for you, kind of segueing into the more psychosocial and existential aspects of caring for ILD patients. What are some indications that there may be suffering on the part of the patient and or their caregiver that are not just physical suffering, right? Because we know, and you know, because you're married to a palliative provider too, that not all suffering is physical, right? And I think you see that in critical care. I think you see it in advanced lung disease. But if you're talking to a provider who's going to see some of these patients, patient comes in, what are some cues that should kind of alert us as providers to say, hey, there's some other kind of suffering going on here that perhaps is psychosocial, that perhaps is existential? And then how do we, as the combined teams, right, we're in partnership here, help address that for both patients and their caregivers? Because I think that sometimes the people who get most marginalized in all of this is often the caregiver.
Absolutely. I think, some of the ways you identify that, some of the psychosocial symptoms are developing is, we know that depression and anxiety are very, very common in this patient population. Close to 50% of the patients will actually suffer from depression, and the role that plays in actually reducing their quality of life more so than the disease itself, is quite significant. And I think knowing your patient, what they enjoy, what they do, in their personal lives, I think provides the window into them. That I used to go down to my garage to do some woodworking, and I've stopped doing that. Or I used to enjoy walking my dog, and I'm having difficulty doing that, and for that I feel quite sad that I cannot do that. That was my favorite thing to do, to walk with my dog. And I think some of those are kind of the clues one can use. I think there is a questionnaire. It's not on top of my head, but there is needs assessment questionnaire one can use if you want to be really formal about going about inquiring those symptoms. But I think oftentimes those are some of the clues that the patient may need some help in addition to to address their depression and anxiety that are so common. 1 in 2 or 1 in 3 patients will actually have that as a concurrent symptom.
Mm-hmm.
And so, in our cancer clinic, I'm embedded in our cancer clinic here, and one of the things we do is a psychosocial distress screen, right? Which is a routine document. There's several versions available. You can implement it into your clinic or your EMR in a fairly straightforward way. So if you see this distress, let's say your patient or their family tells you like, oh my gosh, he used to love going into his garage and tinkering with his engines and stuff, and now he's not leaving the living room. What would be, at least for the purpose of at that visit in an immediate sense, what are 1 or 2 strategies to kind of implement or start to help try to address that? I mean, I know there's more longer term stuff to keep working on, but just that, what is an in the moment support that we can offer these patients when we're seeing them?
Yeah, it's about, again, putting the question back to the patient that, Mr. Smith used to enjoy doing that. How about if I can help you to get back to what you enjoy by, whether it is a drug therapy, whether it is a counseling, whether it is actually addressing whatever the worries, that they have that comes with the disease. I think asking that open-ended question to the patient about how much, they think they would like the help. And that often opens up the conversation about what they're willing to and not willing to accept from us as a healthcare team. And I find that, as a very effective way to, inquire about. Ultimately, patient also would want to be a partner in their own care with us. And I think we oftentimes don't ask enough open-ended questions to the patient to elicit some of these, potential preferences that patient may have regarding this area. So I find that that's, probably the best ways to inquire about that and address right at that visit. And then we can, once we meet the patient where they are, we can figure out the strategies to, help them, whether that's pharmacological treatment, whether there's the support groups, that are actually, run by, various, foundations. I think finding them that community to talk about their symptoms with the patients going through the same kind of diseases that they are going through. There are various resources one can use. Palliative medicine, again, comes handy with their social worker, their chaplain resources that are embedded within their model. So I think we can meet their, not just their diseases as such, which we call, depression, anxiety, but their, other needs that they may have, which are often not visible to us, as straightforward lung doctors.
Dr. Mehta, I'm so glad that you had mentioned about really, and earlier in the conversation, really bringing in the troops and that support around and adding into moving forward with your patient and their family is using resources outside like patient advocacy organizations, support groups, educational type opportunities through the conduit of patient advocacy organizations. So I'm so glad that you had mentioned that. That is something, in part of that conversation is a very helpful resource for folks. And I think thank you. I appreciate you saying that because it's important. It's really important.
Certainly. We have patients who are part of the support groups, and, the stories that they tell me, after they've been to that and what an impact that they had, during that is, certainly, left a, kind of a print in my brain. That this is something that's valuable to patients and oftentimes their loved ones. They go with their spouses and they have their, a little bit of coffee and a conversation, and that goes a long way.
It does.
And quality of life as such.
Absolutely.
I agree. So Dr. Mehta, I have to ask you from the overall perspective, right? You have this intersection of a very advanced, fatal, complex lung disease and the space between where that's discovered and trying to be managed and where palliative medicine can intersect. So if you could tell us, like, in your perfect world, what would the ideal collaboration look like from the perspective of the advanced lung disease physician, with the collaboration or partnership with palliative medicine? Like, what should that really look like, in your eyes?
That's a great question.
I know each other.
That's a great question, Patty. I think, ideal world, when you talk about ideal world, here is what the ideal world should look like for patients with, IPF or other advanced fibrotic lung disease, is that here, this is a clinic that actually is a multidisciplinary clinic that not only includes lung doctor, but includes respiratory therapist, social worker, and palliative medicine, embedded within that same multidisciplinary clinic. There are lots of multidisciplinary clinic models. Oftentimes oncology, appointments, if they occur in that, fashion all the time, that you see, not only your oncologist, you see a radiation oncologist, you see, other relevant specialties. So there is concept of this multidisciplinary clinic that is not just, involves lung doctor, I think would be the ideal world. We don't always have the resources at every locations, to do that, but that Patty would be, ideal, for, if you ask me what the ideal world looks like, that really what we should aspire to provide, for the patients. One-stop shop for, for the person, not just the disease.
Yeah.
And then that's where I think it helps both the patient and the family and the caregiver the most, right? When there's this wraparound approach to care. And so, I know our time together is kind of drawing to a close. And so I wanted to add, Dr. Mehta, you've taught us a couple of really important lessons, right, through the last hour. So, and I think some of the important takeaways are, be curious, not judgmental, in the words of Ted Lasso. I also think that it's super important to kind of know that the early integration, the early recognition of the disease. So if you're seeing a patient in pulmonary clinic with some subtle changes, some changes on exertion or tolerance to activities, to really start questioning it and not being as dismissive and saying, oh, it's age related or it's just a weight gain issue, but to be willing to dig a little deeper, and that answers can be gotten from things like a really thorough comprehensive pulmonary exam, a thorough PFT, an oximetry test if necessary. I think that it's important to recognize that the early referral to transplant, oxygen therapies, rehab can't be stressed enough, the support. But what would be, if you had to tell a new pulmonary provider coming into, managing some advancing lung disease in these settings with ILD, what would be like 2 or 3 top takeaways that providers in this setting could kind of start implementing today to do better in the care of these patients?
Yeah, I think, learning about the threshold for referral, like I mentioned earlier, when is the right time to refer? That's number one. Number two would be actually introduction. And sometimes it does require a little bit of role playing what we did today, that how to introduce the concept of palliative medicine for these, folks. While you deliver, disease specific therapy, I think will be the other. And then a little bit of what I call a primary palliative medicine versus a specialty palliative medicine. So all of us really need to become a little bit of a primary palliative medicine provider, where we introduce the concept, we introduce, the benefits, and then, bring the really, specialty palliative medicine, which are the palliative medicine providers who are trained and equipped with all the knowledge that they have. I think those are, kind of the, practical, advice, that I would give. And I think removing that taboo regarding palliative medicine, equivocating that with the end of life and hospice care really needs to, we need to amplify that. I think there's room for improvement, in that.
And I think as providers, that's something we should rise to the challenge with, right? We are an enlightened group of educated professionals, and we are perfectly able at this day and age to be more enlightened about something, to be willing to kind of discard an old misnomered kind of categorization of the service, and to really kind of just say, in the work of serving a patient with advanced lung disease, there is a space for a partnership and a collaboration across the board, with an advanced lung disease provider, with palliative medicine, with the caregiver support resources and education, and to really kind of say that is really how we optimize, whole person care, right? And I think that, really the biggest takeaway that I keep hearing from everything you're teaching us today is that the curiosity about a patient and their life matters. That willingness to sit down and kind of explore the issues matters, and that willingness to dig a little deeper is important, right? And I think, we're lucky to have someone who kind of has that dual perspective of, I'm an advanced lung disease physician, I will bring, the forefront of medical therapies to you, but I'm also, going to balance that hope with realism.
Absolutely. I think I couldn't agree more, Patty. Well, I think you summarized that perfectly
beautifully.
Better than I could.
You said it all, right? I mean, I think that's been the key of this last hour together, is that there's this partnership to build. And so we do have to kind of leave our issues at the door and say, we're here to all serve the same person. So let's all, rise to the top of our levels and just the top of our abilities, and do that in partnership, respectfully with each other. Because in the end of the day, the person who benefits the most is in fact the person we're serving.
Absolutely.
Our patients and families. So, I'm super thankful that you were able to take time out of your schedule today and join us. I know that we took a lot of your time today, but I appreciate you very much. And I look forward to an opportunity to kind of pick your brain in the future. Future topics.
Thank you, Dr. Mehta. We appreciate you.
Thank you for your kind words, Patty. You're an old friend, and Jen, it was a pleasure to spend the hour with you and talk about what is my passion is interstitial lung disease in general. Thank you for the opportunity.
So on behalf of the American Thoracic Society and the Breathe Easy podcast, we are going to end our session today, and thank you all for listening. We've been spending this last really good hour with Dr. Yatin Mehta, who heads up advanced lung disease and interstitial lung disease management at the Geisinger Health System in Danville, Pennsylvania. Thank you.
Thank you.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.